It is January 14th, 1:03 in this meeting of House Healthcare. Today we have Nolan in our JFO, and he is going to start us off where we should all be starting, regardless of if you are a new member or a veteran member, with Healthcare 101. Leslie, we have your slides.
Should be posted.
I'm not showing any documents posted.
That might be my fault because it don't post it till just before I go on.
Might take a minute.
We will get them posted. Do you want to put them up?
I was going to, yes.
Or did you want to talk first before you put them up? So we can see you.
Either or, I'll pull it up. For the record, Noel Nangwell, Joint Fiscal Office. So, this presentation I'm going to present today, it's a combination of a high-level overview. There's a bunch of slides in here that I will probably blow through really quick, and something I'll spend some time on. The purpose of this is more, just as much for you to have it as a reference later on that you can pull out and be like, oh yeah, I remember for this or whatever. Kind of like an encyclopedia. In years past, I have seen some members that are talking, pull it out, and, pull out, try to, oh yeah, okay. This is really meant to help give you a foundation. You're going to have a lot of information thrown at you, and everyone's at a different space in terms of their understanding of Medicaid. We have Medicaid auditor in the room, and we have folks who've never done Medicaid. We have people who've heard this presentation 4 times, which, by the way, if you've heard this presentation 4 times, you are required to laugh at all my jokes, even if you've heard them before. Exactly. Thank you, Tina.
If you've seen one presentation, you've seen one.
Exactly. You're getting ahead of the punchline. So anyway, this presentation is meant to be sort of a high level overview. I don't know that we're going to get through it all, but we're going to do our best to try to. Feel free to stop and ask me questions. And if I think we're going down a rabbit hole, I may kind of flag it and say, well, let's move on. Because so many of these, you can go down a rabbit hole real fast and waste a lot of time. Some of it's worth it. Sometimes it's not.
And just for the committee, Nolan's going to be in several times this week.
Sorry. I don't know what happened. Why is it doing that?
Your sound. Rewind.
One second. Got it. Thank you.
So Nolan's going to be in doing some 101s several times this week. So sort of more in depth on certain topics.
So welcome to Vermont's healthcare system. So my first thing I start off is with a disclaimer. I try to use, there's gonna be a lot of charts, a lot of numbers, a lot of graphs. I try to use the most up-to-date data possible. There is the two of the presentations that I used, or reports that I use the most numbers have not been updated in quite a while. One is the Vermont Household Health Insurance Survey. That hasn't been updated since probably 21 or so. That's one that gets updated probably every 3 years or so. It should have been updated a year or 2 ago, and it wasn't for whatever reason, but I did see that there's money in the budget adjustment for it. So I think it hopefully will be forthcoming this year. It'd be really good information to have for post-pandemic health insurance coverage. We don't have that. Second document that I use, or report I use a lot, is called the expenditure analysis, and that's put out by the Green Mountain Care Board. That's a document that sort of lays out all the spending on healthcare by different payers for different providers across Vermont. There's always a 2-year lag. So in theory, we should have the 2023 data. We don't. I've talked to the Green Mountain Care Board quite a bit about it, and to their credit, it has a lot to do with vendor issues and personnel changes, and so they are working on it. They're aware of it, but in the meantime, a lot of the charts that I have are a little outdated. I'll flag where they're outdated and say, here's where I think it could be, or here's where, but most of the time the underlying point is still the same. So that's my big disclaimer, because a lot of times people think, oh, they're going to get this 24 data. Where we are going to get 24 data is when we're talking about Medicaid and Medicaid coverage. We do know how many people are in our Medicaid programs. We do know that stuff. What we don't know is how many people are in Medicare or uninsured or in private insurance. That we don't know. And that's where the household insurance survey comes in. And that's where the expenditure analysis comes in because it talks about how much spending is by those different payers. We know Medicaid, we don't know everything else. So that's my disclaimer on that.
Should we ask questions as we go or?
Feel free.
No, I'm trying to formulate it quickly. You just said that is the budget adjustment, that there's going to be an appropriation for this survey.
Mhm.
When would the results come back?
My guess, and this will be something that I imagine Commissioner Levine will talk about, but usually there's often done at the end of the year. So I would suspect that if it passes budget adjustment, they'll probably be working on contracting with the vendors through the summer, then laying it out. And usually they often do these things in the fall, and then usually by January or February of next year, we would get the results.
Excellent. So a year from now,
That's what I suspect.
that would be the best outcome though. The soonest would be a year from now. All right.
That's my guess.
Thank you.
Good question. So I tried to break this presentation up into these four parts: patients, providers, payers, and regulators. So I start with the patients. These are really this is like just a high level overview of population, but this is sort of like the premise of people say, well, why is our spending going up? Why is Medicaid cost so much? Well, it's many things. It's not just one thing. But one of the things I want to point out is like we saw a big population increase, around 2020. And so you can see that in 2019, our population for a total state was 623,000. By 2023, 2019 was 623. By 2023, it was 647,000. So we did have this spike. The other thing I want to point out is births versus deaths. And you can see that in around 2015, between 2015 and 2016, our deaths surpassed our births. So that's one thing that kind of shows that is a contributing factor to our population. The other thing that's contributing to our costs is, well, the median age, right? So you can see that in 2010, which is the white, and in 2022, which is the blue, you can see that certain populations, our young populations are decreasing and our older populations are increasing. So we've heard about how Vermont is an aging state. Well, this is something that's going to contribute to healthcare costs. The older you are, the more we're going to cost.
Do you know if the rate of the increase of the elder demographic is curving down yet?
I don't. No, I haven't done any analysis of population estimates.
Just thinking about the increase in rates of death numbers, rate.
Yeah, I don't know off the top of my head. So, but this is just meant to point out, just like we're an aging population. I'm gonna skip this one and move to providers. So we're gonna start with hospitals. Hospitals are a big part of our healthcare system. We have 14 hospitals. We have one level one trauma center, which is the University of Vermont Medical Center. All of our hospitals are not-for-profit, and we might be the only state that is. All of our hospitals not-for-profit, and that's because we don't have a lot of hospitals. We have two psychiatric hospitals. One is the Vermont Psychiatric Care Hospital in Berlin, which is run by the state. And then we have the Brattleboro Retreat, which is private. Then there's Dartmouth Hitchcock, yes.
Where does the Wyndham Center fit in?
I don't know.
Okay,
I'm
I
not
was like, I think it's a
sure.
psych hospital, Wyndham Center.
I think I get to that when I get to mental health, I think I talk about
That's
that.
an inpatient facility. That's the only, I mean, it's in my
It's-
district,
I
right?
mentioned it in my mental health
Got
section, so I think it counts. We'll get to that.
Yeah,
Then there's Dartmouth Hitchcock, which is not part of Vermont. It's in New Hampshire, but a good percentage of Vermonters go to Dartmouth Hitchcock. I don't know what the migration is in terms of people from Vermont that go to Dartmouth, but it does impact our system, and then we don't regulate that. So when we think about what are things we can control and can't control, that's an area that we don't have a lot of information on.
is Dartmouth Hitchcock also nonprofit?
I don't know, but
Yeah, I think so.
Rep Goldberg, well, it's part of maybe because it's part of the university. I don't know.
I'm gonna look, but I'm pretty sure.
Do we know how much monies go out of Vermont to Dartmouth?
I don't know.
Woody, can you repeat that?
I'm just curious how much monies from Vermont leave the state to go to Dartmouth.
Again, because they don't have to report to us, I don't think we know. Our payers probably know how much they pay to them, but that's not going to paint the full picture. So I don't know that we know currently, I don't know, maybe somebody does know what our migration to Dartmouth Hitchcock is. But then also remember that Vermont gets quite a few people from New York who come to Rutland, who come to UVMMC. I think Ascutney gets a fair amount of people from out of state. And I have a slide later that shows the migration, actually, probably the next slide.
Are you counting CVPH?
I just want to remind people to please raise your hand if you have a question. Brian, did you have a question?
Yeah, well, it was a quick one. Sorry, people had broken that protocol, so I was just following. Is CVPH included here under UVM Medical Center?
CVPH.
It's Champlain Valley Physicians Hospital. It's in Plattsburgh, but it's part of the UVM Health Network.
If it's not in Vermont, because there's other UVM, they also have Plattsburgh, they have all these other
Yeah.
stuff. That wouldn't be counted because we don't regulate out-of-state hospitals. Even if they're owned by in-state entity, we don't regulate it.
But we don't regulate Dartmouth Hitchcock, right?
No. So we wouldn't regulate them either. So we don't have I don't have any information on it. But it's a good point that like there is some in and out migration.
And they're also part of the budget of UVM Medical. I would assume they're part of the, but I don't know how Green Mountain Care Board manages that. We can look at it another time, but they're part of UVM. So I'm curious how that plays into the numbers.
Yeah, I think that when the hospitals, and if they can confirm this,
Yeah.
hospitals do specific hospitals. So Central Vermont, they're part of the UVM network, but they provide their own hospital budget. UVMMC does its own hospital budget. I don't think the health systems come in and provide their budgets. It's hospital by hospital. But we can confirm that when they come in.
Thank you.
This chart is meant to just sort of show the patient share by net patient revenue by spending of all the different hospitals. And you can see that University of Vermont Medical Center accounts for 47% of our net patient revenue, followed by Rutland with 11% and Central Vermont with 10%. So this just kind of gives you a sense of how it's spread out.
I'm raising my own hand. Alyssa?
You're allowed.
Do we have historical data on this? Is this information that Green Mountain Care Board has collected? Previous, so we can see, I'm just wondering about maybe the movement of net patient revenue.
They've been collecting net patient revenue forever.
Okay,
And so they could easily, it's analysis that have to be put together, but I'm sure there could be something that shows each of these over time. You'd have to ask them for it.
Leslie, did you have a question?
Yeah, could you talk a minute about net patient revenue? I mean, that's coming up all over the place and we're being yelled at as the wrong measure and blah, blah, blah. So I don't know if this is the place to talk about it, but if you put it on your list, that would be great.
Sure. I mean, net patient revenue is supposed to be the net patient revenue you take out, like you take the gross, which is the total, and take out the expenses, right? And then it's supposed to be, it's a formula. Now I won't get into the weeds of like what's in and what's out, swing beds in or out, but like in theory, it's supposed to be what their patient revenue is after their expenses.
But the group, man,
Yes.
but my understanding, the Green Mountain Care Board, when looking at hospital budgets, is asking them in some cases to reduce their net patient revenue.
Mhm.
And how does that fit in? Fit
into what?
it's a bit of a mystery, and we maybe need to go another time.
I think that we will have in here relatively soon, we will have the Green Mountain Care Board in, because as you did point out, this is a topic that keeps entering conversation, and we'll get a thorough overview of, just like the hospital budget process, and, what is net patient revenue.
Why it matters is, yeah.
So we'll get into that.
Why they choose that over something else. You could ask
Exactly,
them.
yeah.
Mari?
I'm glad that we're gonna have that conversation later, and I will just say, I don't think Green Mountain Care Board is specifically asking for reduction in net patient revenue. They're asking for something else, and the way that the hospitals are interpreting it is a reduction of the net patient revenue, and
That's the confusion.
there's an issue there.
Yeah, lots of confusion.
Okay. So again, these are old numbers, but from 2022, but the total operating expense for Vermont hospitals was $3.5 billion. There were a total of 238,919 visits to Vermont emergency rooms that did not result in an admission. So that's just people coming in and then coming out. These points are really just to show you like the volume of these hospitals. UVMMC accounted for 21% of those visits. There were 44,618 inpatients. The average length of stay was 5.8%. Those aged 65 or older accounted for half of all inpatient discharges. So again, you get the sense of older population using a lot of the services. Medicare was the principal payer, over 50% of the time. Again, older population. University of Vermont Medical Center accounted for 44% of all inpatient discharges and 64% of total inpatient charges. So again, they're bigger, they have more beds, they're going to have more volume, but they do account for a lot of, so it's not it just is more just to kind of get a sense of the volume and the mix of where people are going and where the revenues are.
Can I interrupt you for a very simple clarification? Do you think you could explain to everybody, it's my goal at the end of the week that everybody will know this one thing. Can you explain what the difference between Medicare and Medicaid is?
I do get to that. I have a whole
You're
slide.
gonna get to, okay,
Yeah.
all right, well, I'll wait till you get to the slide then.
I will.
We're throwing out Medicare numbers.
Oh, I have another question while we're paused, sorry. Since we recently lost a member who might ask this question and do us all a huge favor. Can you talk about inpatient and outpatient visits? Or what the difference is between inpatient discharges and outpatient visits?
Yeah, an inpatient visit would be someone who stays overnight. I believe, unless they might not stay overnight, right? They're admitted. It's people who are admitted to the hospital. They might be discharged the same day, but people who are admitted. An outpatient might be, I'm doing an outpatient procedure, I'm having a growth removed or something like that. But I'm not the expert on inpatient versus outpatient. We do have an expert here.
We do. Would our expert on inpatient, outpatient like to chime in on that?
Sure. My less than expert statement is that you can be an inpatient and not be admitted. I think.
Observation staff.
Yeah, observation status is in effect for an inpatient admission until a certain point, and I can't remember if
24
it's
hours.
2 midnights or 1 midnight or there is a classification for inpatient that's not admission.
And a lot of it's coding, right? And the coding is what they use for billing.
Brian?
Does outpatient also include primary care visits to facilities run by UVMMC?
Now, I'm not sure I can answer the inpatient, outpatient question to the level of depth.
We'll ask.
I would say, basic, I have the basic premise, but if you want to get into what counts as an inpatient versus outpatient and the scenarios where it could be one or the other, I'm going to defer to when the hospitals come in and do their presentation. So I would just ask maybe put a pin in it. Great question. I won't pretend to be an expert on all things healthcare,
Thank you.
but they're great questions.
It's a great question because I'm sitting here looking at the numbers and I'm thinking to myself of all the things that are outpatient visits, that there is no way it can be 140,000 to include 238,000 emergency department visits,
You're thinking,
which is technically an outpatient visit.
you're thinking more.
I'm wondering what the outpatient is,
Yeah.
but let's not get.
So you
Let's,
can get bogged down and the idea is that the 238 may have a different definition. So this is really meant to just give you a sense of volume without getting into the weeds. And the 12 times I've given this presentation over the last million years, no one's ever asked. So.
Thank Art Peterson for inspiring that question.
And we love, us, we love the weeds.
This is the inpatient, outpatient slide. Again, this is a little outdated, but it's meant to give you a sense of where out-of-state residents are. So for instance, you can see then the hospital in Bennington, 20, this is by inpatient discharges. They have a larger percent of outpatient, they have a 29% of their inpatients are out of state. Mount Scotney is pretty high. And then this is to give you a sense of the in-migration. And then we don't have the out-migration in terms of how many people go to Dartmouth Hitchcock. But what we do know is where people seeking care in Vermont are coming from. Again, this is from 2020, and you can see of the people seeking care in hospitals, most were Vermonters. New York was 9.3%. So again, that's probably the folks going to UVMMC, followed by New Hampshire, and then other, and then Massachusetts. So again, this gives you a sense of that in migration. Whether how that's changed over time or whether the same, I suspect this probably hasn't changed a whole lot. Another important part of our system is the federally qualified health systems. You're going to hear from them as well. So you can ask me questions, but I might suggest you reserve your questions for them. The organization that oversees, or no, the organization that represents them is called Bi-State Primary Care. So I imagine you'll be hearing from those folks. What FQHCs are, they're federally qualified. It stands for Federally Qualified Health Centers. They are defined by federal law. They have different criteria that they have to meet in order to be considered an FQHC, such as being located in an area of high needs, have a patient majority governing board, acceptance of all patients regardless of ability to pay. Apparently there's over 90 requirements. But they often focus primarily on primary care. But they also receive different rates from the federal government than normal hospitals would. So it's a different payment model and a slightly different purpose than a hospital. They provide all kinds of, some of them provide dental, they also provide psychiatric help, not psychiatric, mental health. So they're an important part of our system, and I will defer to them to explain more about them when they come in. This just gives you a sense of how many there are and where they are. So there's 11 FQHCs in Vermont. They have 92 primary care sites across all 14 counties. And in 2023, they served over 198,000 Vermonters. Another important part of our healthcare system is the long-term care system. I believe most of this probably falls in the jurisdiction of the Human Services Committee. There are 36 nursing homes, 33 of which participate in Medicaid. There's about 2,900 beds. There's also 9 home health agencies, 18 assisted living residences, 85 residential cares, and 9 hospices. What I'm trying to do here is just kind of give you a sense of the lay of the land of the different places that provide care. Mental health, important part of our healthcare system. Providers of these include designated agencies, what we call DAs, and specialized services agencies, SSAs. This would be, you're going to hear from Vermont Care Partners. They're the ones who represent them. We also have designated hospitals, the Brattleboro Retreat, and then Vermont Psychiatric Care Hospital in Berlin. This presentation kind of goes into a little bit of detail about, I'm not going to get into it, but this document sort of explains, well, what makes a designated agency? Why is it called a designated agency? So I actually included the spot in statute that basically created the designated agency and what their purpose is supposed to be and how we work with them. But I'm going to leave it up to them to talk more about who they are and what they are in depth. I will say that there are 11 designated agencies and 7 specialized services agencies. We have designated hospitals, which are hospitals that have inpatient psychiatric units. DMH, Department of Mental Health, currently designates 6 hospitals to provide psychiatric care. That would be Brattleboro Retreat, Central Vermont Medical Center, Rutland, University of Vermont Medical Center, VA Hospital, which is in White River, and Wyndham Center at Springfield Hospital. Then there's also the Brattleboro Retreat. I won't get into details about them, but they are a private nonprofit hospital. And then we have the Vermont Psychiatric Care Center in Berlin, which is Vermont's primary hospital for involuntary mental health patients. It's run by the Department of Mental Health, and it has 25 beds.
Michael. Nolan, sorry. I don't think that the Central Vermont Hospital has that psychiatric unit anymore.
I think it's still currently open for the time being.
I did run this slide by Department of Mental Health and the DAs to make sure that they were all correct.
Yeah.
So
it's still open then?
according to what my slide said, again, DMH will be in here soon enough. But I did run these slides by them. Every year I send the slides to the Darius experts in the field to say, are my numbers correct? My number of nursing homes correct? Is my number of DAs correct? So this is what they came back with. It's a good question. I don't know the answer to.
Daisy has a quick question.
Before you move off of mental health, I didn't see if it was on your FQHC slide, but they are required to provide mental health services as well. Included in those 90 requirements is mental health, substance use treatment, and dental.
I do have that. They're offering including primary care, dental, oral, mental health, and enabling services.
Enabling services?
I don't know what that is. I copied that from.
Oh. Substance use, thank you.
What's enabling service? I'll look it up.
Yeah, I should have looked it up when I put that in there.
Leslie, since we're setting the table, FQHCs are financially very stressed. And the FQHC primary care provider in my community closed as of January 1st, moving all primary care from my community.
I think by state will be in
I don't think by state has anything to say. But
relative,
I'll be cynical about that.
relatively soon. Brian?
Yeah, I looked it up quickly and it says enabling services are non-clinical services that help people access healthcare and improve their health. They can help people overcome barriers to care such as social determinants of health and reducing health disparities.
Thank you. So this, again, my plan was to sort of, it's in the document. I'm going to blow through some of these pretty quickly, but you can always go back. It's more just to kind of point out like how dynamic and vast our system is and what's sort of included. And if you ever want to go back and how many FQHCs there are, or whatever, this is to help you know where they are. But we're going to be hearing, or you're going to be hearing from them, and you can get to more of the deeds and the details of those specific things, because I'm not the expert on them. So this is all slides. But workforce is my next thing I want to talk about. This is really important. This committee has spent a lot of time on workforce. So I'll talk about physicians, nurses, dentists, even PAs, just to give you a sense of what the numbers are. Each year when I update this presentation, I try to find the most recent report for these. Department of Health try to update each of these workforce reports every couple of years. So I went back and I tried to look at the change in different things. This was something I did over the summer. So we have 3,100 physicians providing care in Vermont, but that translates into 1,394 FTEs, full-time equivalent. So that would be, so you have 3,100 people who are licensed and providing care, but they may work part-time. So that 1,394 is supposed to translate to what would a full-time equivalent be when you take all the part-timers into consideration. And then that includes about 980 who provide telemedicine only. And that excludes residents and fellows. 20% or 30% of the FTEs provide mainly primary care. So it's less than half are primary care. While there was a 26% increase in the number of physicians between 2018 and 2022, it only translated to a 2% increase in FTEs. So we saw a 26% increase in the number, but in terms of most of those are part-time. All the growth was in specialty care. Primary care actually saw a decrease in the number of providers. The increases were especially large in hospitalists and emergency medicine. And some specialties saw decreases. So it's not just like all specialties are increasing, some saw decreases, but I'm trying to give you a sense of what is happening with our workforce. Again, it's a couple of years old, but we do have an aging workforce, which I get into in the top. Now down here, 65% of our physicians are 45 years or older, and 26%, more than just slightly over a quarter, are 60 or over. So again, this gives you a sense of our workforce. And 20% graduated from medical school or completed residency in Vermont, while 8% graduated from UVM and were residents in Vermont. So just because we talk a lot about medical education in here as well.
And we're just referring to physicians here.
Yes.
MDs, DOs.
Yeah.
Okay.
And now I have nurses.
Wait, Tucker, did you have a real quick question?
A quick one. And is there a figure that says there should be so many physicians,
There have been reports.
excluding the specialties?
There have been reports done over the years by commissions and other groups that made up of stakeholders and the state that have come out and said, this is how many nurses, doctors, whatever, dentists we need. I don't have that report.
For certain amount of population.
But there have been reports that, Laura Pelosi, I think, was like was the spokesperson for that group several years ago, that put out a report saying this is what everyone says is what we need for a workforce. I don't have that number and I don't have that report. But it's out there. And it's true, it's changed. Because there's probably been some retirements and other stuff. Physician assistants, we don't actually have any training programs for PAs in Vermont. There are 356 PAs, which translates to 397 FTEs. 132% of those are primary care. And that's 8 more than in 2016. So we're seeing a little bump in PAs. So 68% worked in specialty care. Again, just to show the age, 44% are under the age of 40, 45% are between the ages of 40 and 59, and 11% are age 60 and over. So they're slightly younger than our doctors. We have our nurses. There was reports in APRNs, so advanced practice registered nurse. We have our registered nurses, RNs. We have our licensed practicing nurses, LPNs. And then we have our licensed nurse assistants, LNAs. And again, I sort of break down the median age, the average age, what percentage are under 44 and over 65, what percentage are full-time and part-time. So this is something that I would just suggest you refer back to. I also have the year that data is from, so you can get a sense. These were the most recent updated for each of these particular professions. I put this together. I try to put this together every year just because I think it's useful and helpful information.
I'm not sure if you want to do this or not, or if this is for someone else, but do you want to just briefly explain what a PA is, what an APRN?
I don't think that I'm the one to describe the different licensure requirements of each of those. Okay.
We'll
Coming in.
Yeah, there are different licensure requirements that have a different level of training, and different level of things that they're allowed to do under those licenses. An APRN can do a little bit more than an RN, which can do a little bit more than a licensed LPN. A PA isn't a physician, but has a lot of the abilities. But I think that a lot of these have to operate under a physician's license, do things like prescribe. But again, there's different levels of training and credentials and licensure to get to each of those levels.
Okay.
But I can't get into what the specifics are.
Okay.
Other than highlight that there are differences. We have our dentists. We have 393 dentists or 297 FTEs. 315 of which were mainly primary care. Again, this shows the age breakdown. 30% were under 40, 40% were over 55. 30% of those are solo practices, ICU. And then between 2017 and 2021, the net number of dentists increased by 12. But we were 14 less dentists were providing at least 30 or more hours of care per week. So we saw an increase, but the hours were decreasing. And then while most are accepting new patients, only half are accepting new Medicaid patients. Presented a page.
Yes. What do you?
Going back to the previous slide with physician assistants, you said there was a bump in the number of PAs and a decrease. Did I understand a decrease in specialty physicians? Are the two related?
I don't know that it's related. I think that each of them happen. I don't know that they're related. I think, a decision for someone to retire or pick a different care has to do with their own individual decision of what they want to train for, right? So I don't know that there's a relationship. And I can't speak to what hospitals, why they hire one over the other. I think that they're probably looking for all of them. So I don't know if there's a relationship.
Right.
If there is, I wouldn't be able to speak to it. Right. You guys are throwing all these curveballs at me. I feel like I'm like, No answers next.
Yeah.
While I'm thinking of it, a question regarding the hospitals. Urgent care centers,
Mhm.
do you have any information on that? And
I don't.
okay, never mind.
No, it's a great question. I don't have an answer to that one.
And as you're laying out, sort of the landscape of healthcare in Vermont, we're not really we're including licensed providers, licensed dentists, licensed physicians. It's not really taking into account individual practices, private practices, or any of that, correct? Like an urgent care center.
It's fairly new in some areas, and it seems to be, I guess it was designed to relieve some of our emergency rooms, and how effective that is, I don't know.
I think we're confusing if it's an urgent care center owned by a hospital. It would be part of the hospital number. If it's a urgent care center not run by a hospital, but by a different private out-of-state or whatever organization, then that's sort of outside of that scope, and I don't have any data on that. And I don't know what data is being collected at the state level on them.
Woody, can I just ask, are you referring to the newest mental health urgent care center that's in the Northeast Kingdom that just opened?
No, I was just, in Newport, there is an urgent care center on Main Street that opened maybe a year or two ago, I think. And, but that is separate from what you're talking about with the Northeast Kingdom Human Services.
Yeah, so I think that unless it's affiliated with your
Yeah, I never
hospital,
thought-
then it would probably be an independent practice,
Okay.
an independent center. Leslie?
I want to reinforce what you're saying, because I think it's important that there are these freestanding for-profit urgent care centers in many communities around the state. And I'm wondering who's in charge of that, who's regulating,
I would ask the board,
which board, the Green Mountain Care Board?
remember, when they come in, I would ask them.
Jen Kirby,
Oh.
Legislative Council. They are not currently, I mean, there's no licensure requirements, and I believe that the way their ownership is structured, they are not subject to certificate of need.
Oh, wow.
Oh, that seems like a black hole there,
Wow.
a little gap.
Mari?
There was an attempt in a prior session to address that. Looking at less people responsible.
Not for a while, because not in my time.
Seems to be like where all employers send, if you need, if workman's comp or you need to get, shots or whatever, they send them to these urgent care. So they seem to be important in the workforce area, yeah.
That was clearly a hole in my presentation of providers. It's a great question. That's good.
Sorry, no one.
No, I think it's an important.
No, I think it's really
piece.
Welcome back, Woody.
That's why we like having you back.
I think we have some organizations coming in fairly soon that represent some of these other levels of care and other types of providers that are not necessarily listed under hospitals or things that we control.
But this is still helpful because the point of these early slides is to really not get into the weeds or pretend like I'm an expert on these, but just sort of lay down like the landscape of hospitals and what they do, DAs, what they do, FQHCs, just so you get a sense of when they start coming in, just like, okay, here's the landscape. Urgent care is part of our landscape, and I did not bring that into the presentation. Well, I will next year, so.
This is off topic, but I find this gentleman striking. I mean, if you look at 300 FTE dentists for a population of 650,000, that's almost 3,000 patients per dentist. And then when you're talking about half are not accepting new Medicaid patients, I wondered if you knew off the top of your head, because I know you look at this, how many children have Dr. Dinosaur?
You'll get it.
I do know how many kids have.
I know, that's what I'm wondering if you know that number.
Off the top of my head, I don't know it. I can get that very easily. But I don't have it off the top of my head. And, there is like, well, anyway, yeah, I don't have that off the top of my head.
I'm just thinking about the
Actually-
number of children in our state that are covered by our state Medicaid plan,
Actually,
and yet we have less than 150 that are actually accepting Medicaid provides them with their dental
I
benefit.
might have that in here.
How
I
shockingly
do have
low
that.
that number is.
You have that in here.
And did it increase at all with the increase?
I think that's gonna be a
in
great
rates that we-
question.
That we provided.
Yeah, because we did recently do something around rates. I think that's gonna be a great question when we get there.
So, I don't have the number on this chart, but you can see 52% of kids under 17 are on Medicaid.
Or Dr. Dinosaur?
Yeah, so if a child is on Medicaid, we call it Dr. Dinosaur. It's like the umbrella name. Under that, we have different categorical eligibility groups, children's health insurance program, or children with disabilities, et cetera, but they just know it as Dr. Dinosaur. So children on Medicaid, we call it Dr. Dinosaur program. So I do have the number somewhere. I don't have it here, but just to give you a sense of the scope, 52% of kids are on Medicaid in Vermont.
Thank you. Sorry.
I'm trying to remember now what slide it was.
Is that primary or is it like, it's also?
That's a primary source.
Okay.
That's their primary source of coverage. What's going on?
Mhm.
Oh, I see what's happening. Forgive me. Don't get dizzy. Okay. Payers, it's a good segue though, into payers. So this is really meant to give a high level sense of what our breakdown of folks on private, Medicare, Medicaid, other. Again, this is from 2021. I don't suspect the numbers have changed too much. Medicaid may have go up or down by 1% or 2%, probably up. Our Medicare might be going up a little bit because of an aging population, but this gives you a sense of where people land. About half of the population have private insurance, and that's a combination of all different types, different individual, small group, employer sponsored. And I'll get into the weeds on that in a moment, but this is just meant to give you a sense. When I talk about public employees or teachers, or when I talk about private insurance, that includes public employees and teachers because it's a private insurance product. So just so you get a sense, when I say private insurance, it includes teachers and state employees.
Brian?
If you don't know this today, it's okay, but what percentage of the private insurance pool or whatever you want to call it is state employees and teachers? Because there's a lot of state employees and teachers. Like out of it's obviously not the individual, right? So out of there's 49% that includes small group individuals and the rest. Out of that 49%, what percentage is state employees and teachers? So I think there's like 40,000 of them or something. So I don't know. I can't remember. I don't want to like give false info, but it's a lot. That's why I'm curious.
It's gonna probably be, you're probably not that far off in terms of the combined
Yeah.
two. But if we have 200 so it's probably gonna be 10% or less, but I will get you a number.
Yeah.
That's a number that I can get you.
And the reason is just because we're hearing about, what are they calling it? That there was a study that was just done. The name is gonna.
Preference-based pricing.
Thank you. Okay, because it's significant because if 10% of 49% is what they're talking about.
Don't hold me to the 10%.
Yeah.
I shouldn't have done math in
We'll
public.
come back to it though.
I should know better. Don't quote me on 10%.
I'm not.
I think we're gonna get a little bit more this Friday coming up.
Great.
Into the insurance
Mhm.
market and we'll have.
I don't have the number in that presentation, but I will have that number for you when I provide that
That's perfect.
presentation.
Yeah, thank you.
So the purpose of this slide, again, this is a little dated, but what it points out here is if you look at 2008 versus 2021, the number of folks that are on private insurance, which is the dark blue on the bottom, and then the government insurance, which is a combination of Medicare and Medicaid, and I'll get into the difference between the two, but that's the government insurance. You can see that 30% of Vermonters had Medicare and Medicaid, and 60% were on private insurance in 2008. And the percentage of folks on those government coverage through up until 2021 has increased while the number of people on private insurance has decreased. So we're seeing this shift from private insurance to public insurance. Now, what did that look like during the pandemic? We had the period of time where we had no redeterminations, which means that we had a lot of people who were losing their health insurance and going on to Medicaid and they couldn't come off. That's going to skew the numbers, but the answer is, where is it now? What does that look like now? And we don't know what that looks like now, but this was the trend prior to the pandemic. So, and that's why I wanted to point out, even though it's a little dated, I think it's important to point out, like, this was the trend. And so hopefully when we start getting back into Vermont Household Health Insurance Survey, we'll have a better sense of what does this breakout look like now? Is that trend continuing for people moving from private to public insurance, or is it time to sort of segue back?
So both Topper and I have to go to a training meeting, mandatory. So I'm going to leave the committee in the capable hands of Daisy. And Daisy, I think your first question is coming from Woody. So if you wanted to move over, and we won't be back before the end of committee. So we'll see you tomorrow morning.
Good training.
All right.
It's a question for me or Nolan.
It's for Nolan. Sorry, Nolan. Military, are we talking active duty? We're talking VA?
In this particular thing, it would probably fall under,
Or TRICARE?
it would fall under, that's a good question. I assume, I don't know the answer to that. If they're getting their health insurance through the military and not through a private insurer in the state. But I don't know if TRICARE falls under that or who is falling under. So that's a good question. I don't know the answer, but what I will say is it's around 16,000 people.
That are getting TRICARE.
Or getting the military coverage, whichever it is. I used to know off the top of my head what is counted in that number. I don't have it off the top of my head. Like, is it just TRICARE, is it including retirees? I don't know off the top of my head. But this is pulled off of a chart. It's meant to give a high level sense. So
Brian?
Just for the future, like, I don't expect you to answer this today, but in my experience as a provider, people with military benefits, it fluctuates. Some of them have TRICARE, some of them have I don't know how to describe it exactly, but it's like a TRICARE plan, but then like Blue Cross Blue Shield or someone is contracted and you bill through them. And so I don't expect it today, but maybe in our ongoing learning about health insurance, we could look at how do veterans and active duty people and, you know, anyone covered by the military insurance, how much of it is TRICARE? How does TRICARE work? Is it, you know, who do they contract with? Because it has changed over the years in my experience, and it's confusing, honestly, and it creates barriers for people with military insurance to get help because it isn't always easy to sign up and et cetera. And I when Art was on the committee, this was an issue that we both agreed on, is like, you know, how do we make it easier for veterans and active duty people to get healthcare in Vermont when there's these barriers. So I don't know, it's just for later, if we could look at like exactly how TRICARE works and, you know, how they contract and with who and et cetera.
I think TRICARE has a lot of barriers. Nolan,
Yeah.
how are you doing? How many more slides do you have? How are we doing on time?
I have a lot of slides, but that's okay.
It's still not posted. I keep checking obsessively.
Well, it went to the wrong place. I don't know if it is.
It should be posted.
It went
Well,
to
what time do you
report.
have?
It went to
So-
reports.
I just,
in the right-
it should be posted.
Oh, great.
It's in the right place now.
Okay. I have quite a bit left, but I think we had scheduled 2 hours for this or
We're here till 3.
Oh.
Okay.
I heard the sigh in the room. Wow. Nobody's making you be here. All right. I'm just kidding.
Where does COVID relief fit into all of this?
Dozens. Most of these charts are pre-COVID, and COVID relief is completely outside of our health insurance coverage, or would be in health spending if it's through the insurer. But that doesn't really fall into the buckets built in or baked in or not included, depending on what we're thinking.
Well, if we were looking at patients, it would definitely show up in the patient's demand for healthcare. And you can't leave that out, right? Like a lot of us were impacted by COVID at the very front.
My husband was on a ventilator for 23 days, and it was actually in Manchester, New Hampshire, because he couldn't get a bed and he had to be on his belly on the ventilator. And we do a Medi-Share, so and they were calling to pay for his bill, which originally was $450 something thousand. And because we were on self-pay, they knocked it down to like $170,000. And COVID relief paid it all.
Oh, yeah, good.
So the insurance didn't even have to pay for it. So
And
that's why it was just,
So that wouldn't fall under any of these numbers. It would be covered under like probably federal relief dollars, a different spot in the budget. It wouldn't really, but it would show up if it was in a Vermont hospital
right.
and they were providing that service, then it would show up in their net patient revenue, right? Their spending,
Okay.
right? So it depends on how we're looking at it. If we're looking at like costs in the system and it's provided by a Vermont hospital, then that would show up in that line. But then it wouldn't show up in the insurance line because insurance isn't paying for it, right?
Yep.
So it depends on what angle we're looking at. Are we looking at from the provider aspect or are we looking at from the payer aspect?
Thank you.
Yeah, no, I think it's a good question for clarifying. And this kind of gets to this similar but different. This is a little data too, but what I like about this is it shows what services are the different payers covering, right? So this is, again, blue is government, so that's Medicare and Medicaid for this, and then red is private pay. So you can see there's certain services that majority of which are paid for through government services. So mental health, home health, nursing homes, it's mostly Medicare and Medicaid. And then if you go, and then you get in hospital and physicians, it's about split in half. Then you get the dentist, it's majority commercial. So it just meant to see sort of the trend in the type of service and who's paying that. I don't think this is going to necessarily change a whole lot with the new net data. But again, this is really meant to just sort of set the landscape of who's paying for what services. So I thought this was a very interesting chart. This was put together by the Green Mountain Care Board. Uh-oh. I see it brewing.
Yeah, I'm just perplexed by that first column that has the
know.
government paying for all of mental health.
It can't be true for outpatient.
Well, I think that what that is probably in their definitions is probably like psychiatric care facility. And then other government activities is also baked in there. So that might be public health, right? But again, what is in their definition? So a psychiatrist per se might fall into physicians, right? So again, it depends on how they are characterizing it in their definitions.
Okay,
So
We can ask the Green Mountain Care Board though, when they come in, because they make this.
yeah, okay, good idea.
I'll write it down.
So now we start getting into private and commercial insurance, and it's broken up into many different types of markets, right? We have our self-insured and our insured, and they often are. So there's so many ways to look at this. You have employer-based, and you have folks that are on the individual market, right? I'm going to step back here for a second. You have folks who get their insurance through their employer, and you have folks who don't get their insurance through their employer, in which case they're either, and if they're not on Medicaid, they're on commercial, they're paying for it themselves. So that's the individual market. For employer-based, we have what's known as self-insured or insured. Now, what a self-insured employer is, actually, I'll get into that in a different slide in a second. So under the self-insured, we have self-insured employers, and then federal employee plan was considered self-insured because the government is self-insuring itself. And then we have large group. Then there's a small group market, which is it's still employer-based, but it's a much smaller business. Again, I'll get into the definition of what is considered a small group or small employer. Then we have the individual market, which you'll see we have what's called qualified health plans and then reflective plans. So these are folks who are buying through the exchange, and or not even actually buying insurance on their own, and they may be buying through the exchange, or they might be buying directly through the insurer. What the little blue stars next to them are those who we as a state regulate, right? We don't regulate self-insured, but we do regulate large group, small group, and individual market. We don't regulate military. So I flag that because when you think about like, we want to do something here, this is what you have the power to control, or what your limitations are to provide legislation on. And this like, again, sort of flags, like you can see what we as a state have control over, right? So Medicaid, obviously we control the Medicaid budget, and we'll get into what is Medicaid. And then we have the small group and the large group and the individual group. So this shows you sort of the scope of insurance in the state and what you have regulatory control over. And we don't do self-insured, we don't do Medicare, we don't do military.
Mary has a question.
It's more a comment. This is one of my favorite slides that I go back to when I'm talking with constituents who are understandably frustrated with the cost of healthcare. And it's frustrating, but I think enlightening, illuminating, to be able to explain to them how little regulatory power we have over the cost of healthcare.
Yeah.
It's a tiny piece.
Yeah.
For a small state.
So approximately half, 49% of Vermonters have private insurance. Most private insurance plans are through employer-based, or employer-related insurance, we'll call it ESI. And so this slide is trying to show like the breakdown. So you take the 49%, which excludes uninsured, military, Medicare, Medicaid. This is just our pure private insurance market. You can see what percentage of those are broken out into self-insured. You can see so 74% of the 49%, right? 74% of our commercial market, which is 49% of Vermonters, are self-insured. Small group is 15%, the large group is 7%, and then other, which I don't remember what other is. Was that?
Concierge?
No, there's something else. I just don't remember off the top of my head. But anyway, this gives you a sense of how those folks are broken out.
But it's not really 74% of Vermonters, right? Because it's 74% of 50% of Vermonters, because the other half is Medicare, Medicaid.
Well, this is 49%
Mhm.
of Vermonters. So it's 74, but so 49% have private insurance and 74%
Those.
of the gray. So, when I made this slide, I was like, is that too confusing? No, it should be fine.
No, it's great.
Yeah.
This is kind of what I was looking for with the state employee thing too, like, so like maybe, and also, now that I'm talking, like, we were just whispering about what about the other, maybe if you can find out by Friday what the other means, if not, no big deal. But what you just did here is exactly what I was kind of hoping to see, like that kind of idea of like, what percentage of this percentage is this, you know what I mean? So this is really helpful. Visually.
No, I haven't.
So what is insured versus self-insured? So in the case of insurer, the regular insurer, so that would be an example of I buy an insurance plan, or I'm an employer and I buy a Blue Cross Blue Shield plan for my employees, or I'm on the exchange. This is the case where the insurer bears all the risk. I buy an MVP plan, I buy a Blue Cross Blue Shield plan. I'm buying the risk. So the employer purchases from a regulated health insurance company, and then they're subject to state regulation. But what self-insured is, in the case would be a large company. The state is sort of a weird hybrid of self-insured, so I won't use that as an example. well, we'll say a large company like, Global Foundries, right? I'm assuming that they're self-insured, they probably are. They're one of those companies that are like, we're big enough that we think we can save money by assuming all the risk ourselves. We'll hire what's called a third-party administrator. So we might hire Blue Cross Blue Shield as our administrator. So still get a Blue Cross Blue Shield card, but what it is they're just processing our claims. But if there's a claim for cancer, we pay the risk, right? But we also might have wellness programs. So we're trying to, and we're going to offer gym memberships. So it might be this hedging bet where we're so big, rather than pay a premium on every single person, it might be cheap. We think it's cheaper for us to just pay the claims when they come, and we'll just hire a third-party administrator to. So it's just the difference of who claims the risk. But they're not self-insured or not subject to state regulation. They're covered. I won't say the E word because it opens up a different can. But that's the basic difference between insured and self-insured. So a quick note, we're going to hear the exchange. So I think everybody here knows what the exchange is. It's under the Affordable Care Act. It's an online marketplace for the individual and small group market. We call it Vermont Health Connect, and it's administered by the Department of Vermont Health Access, DVA, who runs Medicaid, and it's part of the Agency of Human Services. Do you still work there?
I do.
Okay. So then we start breaking down. So this is the small group. So that's the side on the left. We have, this is as of June 2024, so this is relatively recent data. In the small group, there were almost approximately 37,000 people who were covered by these small group plans. And a small employer is defined as up to 100 employees. We have our individual plans, which is the other side. So we have approximately 34,437 people who are covered by individual plans. 82% of those folks receive some kind of financial assistance through the state or federal government. There's two types of, there's actually three kinds. There's the federal advanced premium tax credits, and then we have the state tax credits. So you might hear APTC, that's called the advanced premium tax credits. Those are premium relief provided by the federal government. And then we have another program called VPA, Vermont Premium Assistance, which is an additional subsidy provided by the state of Vermont for folks who meet up to 300% of federal poverty level. And there's a chart up there on the wall whenever I talk about federal poverty level or FPL. I will send a copy to Kristen to post. And it's also on the last page of this presentation. So this is something I think throughout the session you're going to be referring to. What is 100%? What is 300%? It's all in the chart. So you can see that there are, of the people, the 34,000, only 6,000 are not receiving any form of assistance through the state or federal government who are on the individual market.
Brian has a question.
Yeah, and Jen might know if you don't, but during COVID or whatever, the pandemic emergency, Congress, I believe, passed something that said that people would get tax relief if their monthly premiums exceeded a certain amount. And I think that it's connected to the advanced premium tax credits, but I don't want to mess it up. So maybe one of you can clarify, but my question is, when exactly does that expire? I believe it's in the year 2026. Is it fiscal year? Is this the last fiscal year that we're going to get that and Congress has to figure it out now? And if you could just clarify what it's called, because I don't want to butcher the language. Like, is it that the advanced premium tax, what is the APTC? Is it that the APTC is linked to that percentage or?
Go ahead, Jen.
Jen Harvey, I'm the legislative council again. Yes, there was an expansion under some of the COVID relief measures, an expansion of both eligibility and benefit for the advanced premium tax credits. It runs through this calendar year, and then under C1, as I understand it, it expires at the end of this calendar year unless Congress extends it. And if they do not, then it will just revert back to the pre-expansion level, so there's still the AVTC, but at a lower amount.
Can I just say something about this that's brief? That what I finally figured out with the help of the healthcare advocate how to access this. And instead of paying like, I don't know how much is like $800 a month in insurance, I pay like a cent now because I make so little that the tax credit covers that, which means someone who's making like in the 350, I think I'm like 300 to 350% federal poverty line is going to have their monthly expense go up $800 a month if Congress doesn't renew that. Just to put it in perspective, like how hard that is for people, you know? So.
Marion,
Which also means that's something we have to address as a committee this year too, about merging or not merging the individual and small group markets.
So that's sort of a somewhat related, but not directly related to the question of the expiration of the federal assistance.
But if I can, like, having those conversations is why I'm having this, right? Like to sort of lay the foundation so folks can start understanding the markets. And so I'm going to say that's a rabbit hole we shouldn't go down yet, but that's why I'm trying to do this is so you guys can have those conversations. Obviously, some of you can have those conversations now, but I'm trying to level set. So yes.
I'm hoping
thanks for that, Nolan. And people will see what Brian's talking about when you go on the exchange if you're looking for insurance. It does say with subsidy 3 cents per month because I'm looking for health insurance and it's clear on there. It's transparent what your cost will be with the subsidy.
Yeah, and I'm hoping like just that maybe the healthcare advocate could speak more about this when they come in about what it means, because I was sharing one example, but like they could lay out for, you know, population level, what it's going to mean for people in terms of like, can they afford insurance anymore?
Yeah, I'm sure they will.
Yeah.
We've got military. I don't know if this answers Representative Page's question, but coverage based on current or previous military service. This does include VA costs, but I'll get a more in-depth answer to that. That's approximately 3% of Vermonters, about 16,600. Again, this is based on 2021. Probably hasn't changed a whole lot. Then we have our uninsured. So this is the most recent number we have for this is 2021. We don't know what the post-pandemic number is. We don't know if it's gone up, if it's gone down. But according to the Vermont Household Insurance Survey in 21, we had an uninsured rate of about 3.1%, which was about 19,400 Vermonters. 20% of those folks that are uninsured are actually eligible for Medicaid, but just aren't in Medicaid for whatever reason. 52% were eligible for state and or federal subsidies through the Vermont Health Connect. Again, we don't know why they're not signing up for that. They might be young and not need it, or they might be and then we have 33% had access to health insurance, employer-sponsored health insurance. The survey does ask if you have access to your health insurance through your employer, why don't you take it? And 51% said the primary reason was cost. And you saw the slide already. Half of Vermont children are on Medicaid. Okay, Medicare and Medicaid. This is the slide that Representative Black was referring to. What is the difference between Medicare and Medicaid? People often conflate these because the words themselves are so close to each other. Medicare, Medicaid, Medicare, Medicaid. And so it's understand why people might go Medicare, I mean Medicaid, like all the time, right? But there is a huge difference. For one, the Medicare is federal. We have no control over it. We can't do any legislation that does anything around Medicare. It's purely federal. Medicaid is a state and federal program, and the eligibilities are different. So Medicaid is for low income children and adults, of low income children and adults, or those who are 65 or older, blind and disabled. Medicare is all incomes, doesn't it doesn't take an income into account. It's if you're 65 or older, have any, or you have end stage renal, doesn't matter what disease and what age that is, or if you're under 65 with certain disabilities. So again, Medicaid is a state federal program for which we do control, or we have control, within parameters, and I'll get into details of that. Medicare is a pure federal program we have no control over. I think
Leslie.
This is a hack. Medicare has an E at the end, which means elderly.
Oh, good one.
Elderly and stage renal
Yeah,
disease.
but that's a small population, but when you think about it, the E.
You have a hack for us?
No, but we did this last year, but could somebody explain again why we went with 65 and older did not go to Medicare and they turned 65? We kept them on Medicaid. We did that last year.
Get both.
Yeah, those folks will get, a lot of those folks will get, we have this thing called dual eligibility, in which case Medicare is the primary.
Okay.
So they have they're eligible for Medicaid services, but Medicare pays first. And when the Medicare hits their limit, the Medicaid kicks in.
So I thought so. We just did that last
Good
Yeah.
review.
year.
Mari,
Were you thinking of how we eliminated the cliff from when people went from Medicaid to Medicare? There was
We did that too.
Flimby QI1, let's not go there.
No,
a down there, but I think
No,
that
it's okay. That's,
maybe partly what you're talking
I'm
about.
just looking for a refresher of that, but.
Yeah. In short, we have folks that are 65 and older, but they're on Medicare and Medicaid. They're called dual eligibles. They tend to be a very expensive population because they have a lot of needs. Medicare pays first, but Medicare, for instance, might only pay for hospital stays up to a certain amount of time, and then Medicaid kicks in. So these numbers, you'll see I have numbers. It means that Medicare is the primary. If I say Medicaid, Medicaid is the primary. If I say private insurance, because some of these folks have both, right? We have people who are on private insurance that are getting subsidies through Medicaid, right? Through the Medicaid program. Those numbers would count in the private insurance. So this is primary care, primary source. So we know that there is roughly 120 to 230 Vermonters who have Medicare. Most are over 65. We have 1,500 kids under, for whatever reason, because they have a disability of a sort. Again, anyone with end-stage renal disease, I'm not really sure the history of that carve out. And then there's some parts have additional requirements, work history, premium requirements, et cetera, because there's Part A, Part B, Part C, and Part D. I'm not going to get into the weeds of this. It's here as a reference for you to get into another time, but that's why I put that in here. So Representative Black likes to quote me or make fun of me for this particular quote, but like, if you see the joke, no, I don't want to call it a joke, the saying amongst Medicaid people in the industry would say, well, if you've seen one Medicaid program, well, then you've seen one Medicaid program. And the reason is every state, yeah, thank you. I got one laugh. All right.
It was more like I was restraining it, but it is funny.
Yeah. And once you kind of start understanding Medicaid more and more, you'll find it funny too.
Exactly.
You'll be in on the joke, per se. And that's because every state Medicaid program is different. And I'll explain why as I move through these slides. If you are on Medicaid, you would get this card. It says Green Mountain Care. It is the umbrella name for Medicaid. You might be on Dr. D. You might be whatever. Everyone gets this card. It's called Green Mountain Care. It's just their umbrella name. And again, it's administered by the Department of Vermont Health Access. They will be coming in soon enough. So approximately 80 million people nationwide had coverage through Medicaid or CHIP. That's about 23% of Americans. CHIP stands for the Children's Health Insurance Program. CHIP is actually not part of Medicaid in general. It's in separate legislation or a separate section of federal statutes. In Vermont, we administer those children as part of our Medicaid program. So we consider them under Dr. Dinosaur because our Medicaid program administers the program. So we count them as Medicaid, but technically at the federal level, they're not. So in Vermont, we have 197,000 Vermonters who receive some form of Medicaid, including CHIP. Now, this is a number that I always emphasize. You have people who have Medicaid as their primary and Medicaid who have it as some kind of partial or supplemental. So if you hear somewhere, oh, 1/3 of Vermonters are on Medicaid, that's actually incorrect. 1/3 of Vermonters have a relationship or an interaction or whatever you want to call it with Medicaid. A third, 26%, this would be 151,000 Vermonters, have Medicaid as their primary. So to say a quarter of Vermonters, approximately a quarter of Vermonters on Medicaid would be factually correct. Because those 23% of Vermonters, 26% of Vermonters, or 151,000 use it as their primary source. And then another 46,000 Vermonters, that's about 7%, have primary insurance elsewhere. For instance, if you are on the exchange, you are counted under the private insurance market, but you receive a state subsidy. Well, then you fall into this 46,000. Medicaid isn't your primary, but Medicaid supplements your commercial product. So that's why I'm saying you have a relationship with it, but it's not your primary. Or another example would be, we have this program, this is RX Assistance, that's our VFarm program. Well, those folks, Medicare is their primary, not Medicaid. And then VFarm helps them pay for their prescription Part D drugs. I think it pays for their donut hole, which is a whole other weed. But basically it helps provide financial assistance with their Part D drugs and their Medicare.
So you could have commercial, Medicaid, and Part D or V-Farm.
No, you would have Medicare.
You would have Medicare.
Yeah, Part D, V-Farm is just for folks on Medicare, low-income Vermonters who are on Medicare.
In which case you wouldn't have commercial on top of that.
No.
No.
A lot of times these folks are buying, Part D, and they're buying these supplementals or whatever. This is to help those low-income Vermonters pay those premiums or cover the, oh, we have an expert here.
No, not
Oh,
really.
okay.
No, I was just gonna say, in order to qualify for Farm, you actually have to be enrolled in a Part D program. It's Vermont won't.
I think,
What? I didn't hear you.
You have to be enrolled in a Part D.
yeah, it helps pay their Part D premiums.
Okay, so my next question is, I'm a little confused what you said about the CHIP, because I've always thought of Dr. Dinosaur as just our version of CHIP, but you're saying that's not true.
Dr. Dinosaur is the umbrella name for our Medicaid program for kids. So
Okay.
if you're under you're 17 years of age or under, if you're under 18 and you're on Medicaid, you're Dr. Dinosaur. You're just under that umbrella. So that includes CHIP, that includes our general children, that includes children with disabilities, whatever eligibility door they come into. If they're under 18, they're considered Dr. Dinosaur.
Which is broader than CHIP.
Yeah, there's only 4,000 kids on CHIP.
Got it.
So CHIP is just one of many populations under our Dr. Dinosaur umbrella. Okay. It's a good segue. So who is covered? You have to be a Vermont resident, U.S. citizen, permanent resident, non-citizen with lawful presence. I remember several years ago, I worked with Representative Cordes to make sure that we use the proper language to define these people, to define non-citizens. Your financial situation would be characterized as low or very low income and be one of the following: pregnant, responsible for a child 18 years or younger, blind, have a disability or are a family caretaker, someone with a disability, or 65 years or older. And again, those would be our dual eligibles. And then we have our services, what is covered. And under Medicaid, we have services that are mandatory, and we have services that are optional. I do have a slide on that, but we're going to get into a little bit more detail on this when we get into the Medicaid pieces. And I think I'm going to talk about some of it today, and then I'm going to come back and do Medicaid 101, and I'm going to do it again, because this stuff is really complicated, and it does not hurt to hear it over and over and over again. But basically, in short, if a state provides, all states provide Medicaid, and we have a federal match, but we are required to cover certain services. So for instance, inpatient, outpatient, home health, physicians, etc. These are things that we are required to provide. On the other side, we have optional services. These are things that we are allowed to provide and may provide under the federal law, but do not have to. This is part of why you hear, if you see one Medicaid program, you see one Medicaid program, because there's a whole list there's even more sort of optional services that we could be providing. In the time that Jen and I have been here, we've seen Cairo come and go, I think twice, in terms of it being an optional service. And this is, Vermont tends to be more generous. So some states may cover it, some states don't cover it. Some states don't cover dental. We cover dental. It's an optional service. It just means that we're allowed to provide it, and we get federal match to provide that. Global commitment. So this is a term you're going to hear a lot, and you can never hear it too much. Global commitment is short for what's called Global Commitment to Health. And it's the name of the agreement between Vermont and CMS, which stands for the Center for Medicare and Medicaid Services. They're the federal agency that oversees Medicare and Medicaid. And that's the name of the agreement between us and CMS that is used to administer the vast majority of our $2.3 billion program. Should be a dollar sign there. Add that while I remember. Global commitment is what's known as a Section 1115 demonstration project, often referred to as a waiver. So we hear, our Medicaid waiver. We're referring to what's known as 1115 demonstration project, which is essentially our global commitment agreement. And what the waiver does is it waives certain provisions of Medicaid law and gives states flexibility and encourages state innovation in designing their state programs. So again, when we say you've seen one Medicaid program, you've seen one Medicaid program, and almost every state has a waiver. Yeah, at least 47 states have at least one waiver or pending waiver. And this was in 2020. Most states will have we're going to have a waiver for our elderly. We had one, which Choices for Care, or they might have ones for mental health, or they might have ones for whatever, right? Substance abuse, whatever, substance use. These are, and that's just to give flexibility and innovation in those particular areas. We might be the only state that administers pretty much our full Medicaid program through the waiver.
Wow.
Yeah. And basically, these waivers are all different because they basically reflect the state's priorities and goals at the time that it was signed, right? So in our waiver, the idea is to give flexibility to do things, spend federal, state matched dollars on things that we would not have been able to spend money on in the absence of the waiver. One of the major requirements of that is that it must be budget neutral to the federal government. And what does that mean, budget neutral? Because we've had a global commitment waiver going back 15, 16 years at this point, and they get renewed every 2 to 3 years. What global commitment looked like when it was first passed is very different than what it looks like now. It's kind of evolved over time based on the priorities and the goals of the administration and the legislature at those times, and as the needs of the population have changed. So budget neutrality is basically a negotiated, if we didn't have a waiver, what would our Medicaid spending be currently? And so the idea behind it is a cap, right? This is how much we can spend on our Medicaid waivers. It has to be budget neutral, and it becomes a negotiated number between the federal government and the state, what they think that number would be in the absence of the waiver. If we go over that number, over our, whatever the period of our agreement is, our current agreement is from 2022 to 2027, we would be 100%, we'd have to pay 100% of those Medicaid dollars. Now, we've never gone over. We've come close before, but that's not a bad thing, right? Because the goal is to get as much as you can out of it without going over, right? So, but we've come close, and we don't like to get too close because it gets a little nerve-wracking or scary. But anyway, that's the idea, is that it doesn't cost the federal government any more than it would in the absence of the waiver. And then there's all these terms and conditions in which we have to do certain things, and we're allowed to do certain things. And there's a lot of, and I'll get more into detail of that when we do the Medicaid. I'll kind of talk about these things called investments and some of the things for which we are able to do under our Medicaid waiver that we would not be able to do in the absence of the waiver.
How many of those 47, 11, 15 waivers in 2020 were specific to, I think it was Appendix K? Sorry to get wonky, but for CRF amendments, and how many were specific to prior changes? I don't know if that makes sense, but I know in 2020, we did a lot of changes to allow things like telehealth to expand. Is 47,
So there's a difference between amending your existing waiver and negotiating a new waiver. So
right?
that was an amendment to our waiver, right? That's not a new waiver. So I don't understand the question.
Is the 47 states that we counted in 2020,
Mhm.
would that have been the same, even if it weren't during the COVID era, when everybody was applying for a waiver to be able to do stuff like telehealth?
So I don't know what the new number is. I don't think that answers your question, but I don't know what how many states have waivers currently, because 2020 was sort of pre-pandemic, right? So I don't know how to answer your question, or maybe I'm not
No,
understanding
it's
it.
okay. I'll look it up.
I'm sorry.
And Leslie.
So I think I remember this, we did this with hearing aids and stuff, that we can amend our waiver in the
Right.
interim of the contract. So we're
Right.
not totally constrained by our current state.
Yes, there is flexibility. We have to, amendment requires, we have to, apply to the federal government, or it's within an existing language, but there's a whole thing where we do have to like generally get permission to amend our waiver. And we also have to fund it.
Is that something we want to avoid at all? Or is it, I mean, is it a no-go if we have to go down that road?
Amending waiver?
Yeah.
I think we amend waivers all the time.
Mhm.
I think the thing from my understanding or history of working with this, is you don't want to keep doing them all the time, right? But we also, the federal government doesn't want to see that you've funded it, right? There's been times where we're like, well, let's see if we get approved before we fund it. But the federal government often wants proof that you are going to fund it,
Mm.
So there is some give and play on that. But I don't think, we don't want to just keep amending all the time, because it's a lot of work. It's a lot of staff.
A lot of.
I remember when we did that.
Yeah.
Oh,
We had to
and-
do a whole thing.
And to Jen's point, it's also expensive,
Okay,
because there's like consultants have to be hired and staff time and.
so it's something we want to,
Budget neutrality.
yeah, basically avoid but if there's a gap, we're willing to address it. A big gap.
And the waiver is what, 4 or 5 years long, 5 years long?
Yeah, this one's 5 years.
Yeah, so
This is
it's
5 years.
not really a lot of time to amend. I think we've
Depends how
amended
old
this
you are.
twice.
Sometimes we just make a list of things we want to add to the next waiver. Sometimes they go for it right away. It depends.
Wendy has a question.
Are sometimes some of these waivers coming directly from the federal government instead, and so they provide waivers?
No, we have to
They have
negotiate.
Opportunities for states to apply for waivers,
Mhm.
where they, I mean, they're the ones who granted the waiver. Because it's a waiver from their otherwise applicable statutes and regulations. So what we're asking you to do is do something differently than what's otherwise in law, and they have to parameters within which they can say yes or no, and some conditions we have to demonstrate in order for them to be able to say yes, even if it's otherwise.
Okay.
And if anybody's interested in taking a deeper dive into the 1115 waiver, I believe it's on the Office of Healthcare Reform. It's on like whatever VDH or whatever the state's webpage. Office of Healthcare Reform, there's a global commitment page, and they report quarterly every department that is in the waiver. So Department of Mental Health, I know, reports quarterly and annually, and you can go and read their quality measures reporting. It's actually really good.
Okay.
Yeah.
I also have a link to it from the JFO website. Go to joint fiscal and you click on healthcare, and then you click on Medicaid global commitment. There's a link that goes to the AHS page that has everything you want to know, the actual language, all 200 pages of it.
700 pages.
Yeah. Which I have read.
Little weekend reading.
Or skin. But yes, if anyone's interested in one to know this, you can also just reach out to me and I can send you those links too.
Thank you, Nolan.
Yep. So a quick note about dual eligibles. So this is what we talked about. These are folks that are eligible for Medicare and Medicaid. Medicare is the payer of first resort. And again, these folks are counted in Medicare total. So when we say there's X amount of people on 120 to 130,000 people on Medicare, this includes those dual eligibles. There are 22,500 people who are dual eligibles in the state of Vermont. Even though Medicare is the primary source, the Agency of Human Services of Vermont spends over $600 million per year on these folks for healthcare and other support services across AHS. So it's not just their health, but it's mental health, it's substance use, et cetera. All the AHS service for folks who are dual eligible. So because as you get older, your costs generally are more. You're seeking more services, you're on more medication.
Any more joints replaced?
So again, an older number. I don't have a more up-to-date number, but in 2020, Vermonters spent $6.37 billion on healthcare. I suspect this number is probably over 8 billion in 2024.
Over what?
Over 8 billion would be my guess. Medicare, Medicaid, sorry, see, I did it.
You did it.
I did it. We all do it. Medicaid accounted for 27% of Vermonters' health spending in 2020. I don't think this number is going to be that different in 2025. It's a large percentage. Medicare is 25%, commercial 32%. This is the total spending on healthcare. But it has budget implications. So we have an $8.56 billion budget. That's how much was appropriated in 2024 across the whole state of Vermont. Medicaid accounted for 2.3 billion of it, just to give you a sense. It's the second largest spend after K-12 through 12 education. Now, you can look at AHS higher, but I sort of put this line to give you a sense of where Medicaid falls.
Brian.
And just because I don't know the experience of new members and even, or for anyone listening, but you said that I can't see it with my glasses,
2.3 billion.
is what the state put in
No, that's total gross, state and federal.
on Medicaid? I think you just said 8 billion for this year, though.
No, 8 billion for total spending for government. And
Okay,
then,
I thought earlier you said we're gonna spend 8 billion on healthcare.
no, yeah. So yes, 8 billion across the system, all payers. So this two.
There we go.
Yeah, yes.
And so
That's
here's,
the total health spending across the state. And now I'm talking state budget.
yeah, thank you. So that helps because now it's making more sense.
Yes.
And then the other, because the numbers are the same. That's why I was
Yeah.
like, and then, yeah, but here's where I'm leading with it. That out of the 2.3 billion we spent on Medicaid, how much is coming from Vermont's revenue and how much is being matched by the federal government?
I'll get to that.
Okay, thank you. Sorry, I'm sorry.
Question.
And I have a second question I'll throw out there. If it doesn't get addressed today, how does the payer model fit into this and where that kind of, I think that's ending and so I don't want to go down this road too much, but I want to throw it out there that I'm curious about.
That is a rabbit hole I'm not going to go down, only because it's baked in terms of like ahead spending. If it's Medicaid, it's, if it's Medicare, it's baked in there because it's but I believe that's all Anyway, I'm not going to get into the
We can get into it later, but
that's a separate.
Other folks are coming.
Yeah.
That's a separate. It's a great flag, and it's a. I'm not going to go down that
Can
rabbit.
you at least tell us the matching amount though?
Yes, I get to
Okay,
that.
thank you.
I get to that.
Okay.
So overall, again, our total Medicaid expenditure is 2.3 billion. I'm going to do the same exact slide again in 2 days from now, and I'm going to pretend like we didn't have this.
Medicaid 101.
So, but it's 2.3 billion. Medicaid is funded through a combination of both state and federal matching dollars. So in 2024, that accounted for roughly 62% of overall spending. Now, this is not a federal match. This is just total Medicaid. So here's the thing. In our Medicaid program, we have different federal matches. And I'll get to this thing called FMAP in a second. But we have different levels of federal match. We have our standard match, which is around 60-40. We have our CHIP population, 4,000 kids, who get a 70-30-ish match. And then we have our new adult population, which is a subset expansion piece under the Affordable Care Act. They get 90-10. And then the administration costs are 50-50. So the point is we have different match rates for different parts of the program. So we don't have a straight match. Most of it will be the 60-40, and I'll get into the exact numbers in a second.
Okay.
But also built into that federal is grants. Like we also have some federal grants. And so when we look at our total Medicaid spend, 62% of that is federal funds from all those different sources, right? 33% are from our general funds, and then another 4% are from other state funds, and those are generally our special funds.
I need permission. I'm trying to be good at it. So this is another thing for later because we're running out of time. And I don't want to be a fear monger, but the incoming federal administration is saying that they are going to use impoundment pretty quickly. And impoundment can involve deferrals and rescissions. Like the deferrals, you may know more about this than me, but I'm just to explain to others what I'm getting at. Deferrals is the executive branch holding back money that was appropriated by Congress while they try to pass rescissions, which are bills, budget adjustments through Congress. And because,
So I'm gonna,
can we come to that at some point though?
yeah, but I don't want to muddy the waters in the 101.
Yeah,
If you
okay.
don't mind.
Can we do that in like 201?
No, that's like 4.
Yeah,
It
we're,
may be upon us very soon.
That's the problem.
Yeah, because they can rapidly pass bills through Congress
what
now.
I will say is there's a lot of avenues that the federal government could have to make Medicaid harder and more expensive.
Yeah, and that's
And
what
that's one.
60%.
There's a whole other list of other ones I can throw on the table, but I don't want to muddy the water because I want to stay high
For
level
later,
right
for
now.
later, for later. Sorry, it just came to mind.
Sure. So, so federal matching dollar, like I just said, ranges between 50 and 90% depending on the program, their expenditure. Most of those come from, but not all of it comes from our, what we call FMAP. You're going to hear this term a lot. It stands for Federal Medical Assistance Percentage. So FMAP is the share of state Medicaid benefit. FMAP is basically the share the federal government pays. It's calculated, there's this calculation to do, but on a high level, it's basically based on a 3-year average of per capita state income compared to the national average. So when our FMAP goes down, which means the federal government is paying, when FMAP goes up, which means the federal government's going to pay more, which means that every dollar, well, I'll get to that weed in a second. It means that our per capita income has gone down, so it's not a good thing. Like it's a good thing for our state budget. Like, hey, we're getting more federal match, which means it's costing us a little bit less to run the program or to provide some financial relief, I should say, not less. But it might also mean that our per capita income is slightly down relative over a 3-year period relative to the rest of the country. So it's this double-edged sword. No state can receive less than 50% or more than 83%. And so what I've done here is I've sort of laid out like what other states look like, right? So Vermont, we're at 59.01%. This is for federal fiscal year, which is different than the state fiscal year, but this is how this chart was calculated. You can see though, no state can receive less than 50%. And the states that get 50% tend to be the higher per capita income states, California, your New York, your New Jersey, your Connecticut, the states that have a higher per capita income, they sort of max out at 50. Then the states that have the most FMAP or the highest match tend to be the states that tend to have a lower per capita income. Mississippi, West Virginia, Alabama. Mississippi's at 76%. That's a big, big gap. And then the little arrow just shows how they fare compared to last year. Did their FMAP go up? Did their FMAP go down? You can see it's a mix. And then I threw all the other New England states in there too, so you can just see how we fare against all the other New England states. This answers represented Sheena's question. So this is showing the different FMAPs. So for instance, our regular FMAP, which is the vast majority of the FMAP, is 58.81% federal or 41.2 state. What that basically means that for every state dollar we spend on Medicaid, we're getting $1.43 from the federal government. So it's getting $2.43 in services. So in short, for every dollar we're spending for regular FMAP, we're getting $2.43 in services. It cuts both ways. If we cut something in Medicaid, we cut $1, we lose $2.43 in service. So it cuts both ways. So in the past, when we've been in worse financial times, and the state's been looking to save money, if they cut $1 in Medicaid, we're losing $2.43 in savings. So it cuts both ways. Children's health insurance program, again, it's a 70-30-ish match, right? So for every dollar, $3.47. And then our childless new adult, now what's confusing about its title.
Yeah, what is it?
That's basically, long story is that's the expansion. That's supposed to kind of capture this new group of folks that came onto Medicaid as a result of the Affordable Care Act. And at the time, it was meant to provide fiscal relief to states who were going to see these large influxes of Medicaid coming in. And so, in short, it was to provide the fiscal relief, because there was a sense that there was going to be some states were going to have these huge influx of Medicaid people. And we already had VHAP and we had Catamount. We already had a generous program up to 300% of federal poverty, but some states didn't have anything. So federal government at the time did this thing where states like Mississippi that didn't have any expansion, they were getting 100% match for a short period of time on all these new people. And we were getting 80% or somewhere around there. And then over a period of 3 or 4 years, they moved up, we moved down, and we met at 90-10. And so we're all at 90-10 on this particular Affordable Care Act expansion. So when you hear about Congress or the incoming administration wanting to change the Affordable Care Act, this is that group that would be affected. Unless they change, underlying Medicaid. But this is the Medicaid expansion group that would be affected. It's about 41,000 folks in Vermont.
I got a question. You might not know, but out of the 41,000 childless adults, what do they consider a child? What's the age?
Well, it's childless, so they don't have any kids.
Okay.
These are folks that are 18 years and older.
Okay, so, all right, okay, so the other one, under the CHIP, what's the age?
Under 18, but there's a different eligibility group. It has to do with that. There's like uninsured and underinsured. I actually don't know a whole lot about what makes kids eligible for CHIP, but I do know there's about 4,000 kids in that CHIP program.
But eligibility for the childless new adults. Can you talk about that demographic a little bit?
No.
Maybe our healthcare advocate
Or maybe it's on the chart up there.
would be willing to talk a little bit about the childless new adults demographic and who falls into that eligibility criteria.
So that's just the regular Medicaid for children and adults. That's the.
So it's over,
It's an expansion.
over 18.
It's not 26, it's 18.
It's 18.
No, that's a different thing you're thinking of.
Yeah.
So
I'm curious about the age range of the 41,000.
it's up to a certain FPL.
That's what's it saying.
And basically, I can't tell you, I'm not an eligibility expert. What I can say is that if, I think DIVA, I've been communicating with them to testify with me, and they can answer that question when it comes to
We
the
don't have to
Medicaid.
figure it
We
out
could do it in
today.
Medicaid 101
Yeah,
tomorrow or
we
whatever
can do it in
Friday.
Medicaid.
Yeah, we'll do it in Medicaid 101
Yeah.
or 201.
I just want to give you a picture of who those folks are.
Like who the impacted people will be.
Yes.
Yeah.
As a chat, as an advocate.
It's okay, Nolan, we'll
Yeah.
circle back to it.
Things better.
This is great. And I hope you don't take our questions as any kind of like bad thing. It's more like curiosity about what else.
We're going to get more into the weeds on Medicaid, and this is a very short section of regulators, but basically, who regulates healthcare in Vermont? We have a Department of Financial Regulations. Their large piece of that is they look at solvency of insurance companies, and they do licensures. The Green Mountain Care Board, they do rate review for hospitals, and they do rates for insurance companies, and they're a big piece of our health reform. I will let them talk more about their role in regulating in the state of Vermont. Attorney General Office looks at things like Medicaid fraud. We have Health Department does inspections, and then we have our Center for Medicare and Medicaid Services. So anyway, this just gives you a sense of like who's regulating us. And that, I do have some stuff about the Green Mountain Care Board, but I'll defer to them when they come in. But they've been around since 2011. And then we have our federal poverty levels here. This is 2024. The new ones will likely be released in early February, in which case I will provide you with new charts.
Thank you.
That is high level healthcare systems 101. We didn't go down too many rabbit holes. I hope that this helped a little bit in level setting and kind of trying to give you a sense of the landscape without going down the deep roads. We obviously have lots of questions and things we want to know the answers to, simple and complex. Again, I don't pretend to be an expert in everything, but
This is very helpful.
Yeah.
And great
Yeah.
slides
Right.
that are available on our website now, right?
Yeah,
oh, yes, it should be.
thank you for being patient with our questions and looking forward to what else we can learn in Medicaid 101, 201, 301, 401.
And I think we're done for today, right? This is all we have with you.
It is.
Wow, 10 minutes
Okay,
early,
we
good
can
job.